Delegate Hill will get on, and Delegate Chisholm as well. They always attend. So we're on live?
Yeah, just started live.
Okay, thank you so much. So good afternoon, everyone. Welcome as well. They always attend. I'm gonna wait for you to mute, and then I'll speak. Okay, great. So good afternoon. Welcome to the Health and Government Operations Committee. The chairman is Delegate Shane Pendergrass. I am Vice Chairman Jocelyn Pena-Melnick. This is the Public Health Subcommittee, which is actually staffed by our counsel, Erin Hopwood, and my wonderful team member, Edith Perry. I want to thank the members of the subcommittee for being here. We are almost done. We'll be done next Monday, God willing, at midnight. So we still have some work to do and some bills. We're meeting today, but we're also meeting tomorrow. It's my understanding. So you have an agenda that was sent to you by our counsel, Ms. Hopwood, and on the agenda, you have the bills that we're going to discuss today. The agenda and the bills, you have in there the amendments as well as some interlineated copies to make it easier for you to read. We are going to start with House Bill 80, Senate Bill 28. And as always in this committee, we invite all the advocates and whoever has something to say, any concerns to come to the committee. We're pretty open. And for the members, as always, I know I have said this before, but this is your opportunity to ask the questions, please, and to engage. So we are going to start with House Bill 80, Senate Bill 28, Home and Community-Based Services Waiver Participation in Applications. And Erin will describe the bill, and then we'll open it up for the committee and the advocates. Good afternoon, Erin.
Good afternoon. The bill requires the community options waiver to include a cap on participation and a plan for waiver participation of at least 7,500 individuals. If MDH maintains a waiting list for the waiver, each month MDH must send a waiver application to at least 600 individuals on the list, or all individuals if there are less than 600. A waiver application must state clearly and conspicuously that the applicant must meet the application within 6 weeks of receipt and has to meet all eligibility criteria for waiver participation within 6 months of application submission. By October 31st, 2022, MDH must apply to CMS for an amendment to increase the waiver cap size to at least 7,500 individuals. There is a reprint of the Senate third reader on pages 3 through 7 of your packet.
Okay, thank you, Erin. Are there
the House? And sorry, the House bill has not moved in the House.
Okay, but it's just the House is actually the cross of this bill, right?
If you pass it today, you would pass it in the form of the Senate, which did pass the Senate 35-0.
Okay, so this passed 45-0, right?
45-0, I'm sorry.
Yeah, 45-0. Thank you, Erin, for finding that information. I know it takes work, and thank you for working on these bills. So are there any advocates that would like to be heard on Senate Bill 28, House Bill 80? Will you please raise your hand so that I can see you? Okay, wonderful. Then will you go ahead?
Sure. Thank you, Madam Chair and members of the committee. Just here to speak in favor of House Bill 80. This is an issue that's been before the committee for the last 10 or more years. And we had some really strong testimony again this year about the need to overcome this hurdle of the waiting list and really to put some motion into getting more people that will qualify for this waiver onto the waiver, treat them in the community where they want to be, where studies have shown it's better outcomes, it's less expensive to the state. I think now's a great time to really push the ball forward, and this bill does that. It's going to push the cap up to the 7,500. It's going to bring more people into the waiver. We can get the waiting list down. and get it really to reflect the need that's in the community, and not just people signing up to wait 8 years to get into the system. I think, anyway, I'll stop there. I'm here to answer questions, provide any information, but I strongly urge support and passage of this important bill.
Can you tell us how many people are on this waiting list?
Based on the numbers that we've seen, and I guess in the fiscal note, it's around 21,000 people on the waiting list.
And what's the average wait?
Average wait is about 8 years from time getting on to getting an invitation to join, going through the process to see if you qualify, and then if you qualify, the time period to get enrolled into the program. So it's extensive.
And can you describe to the committee what are the people that are on this waiver? What are their characteristics? What are we talking about?
Primarily from our clients, we work with elder law attorneys. I know there's other individuals who apply to be on the home and community-based options waiver, but we're really looking at elderly, those who would qualify for nursing home level of care, but would rather receive that level of care and treatment in their home. So they would be both medically and financially qualified for Medicaid services. This is just a way to keep them from having to go into a nursing home, or right now, or in the past, the way to really get onto the waiver was to go into the nursing home first and then apply, and then move back out of the nursing home and into the community. But the intent of this waiver was to just be able to be in the community and continue to receive care in the community, and not have to take a detour into the nursing homes.
Thank you. Delegate Chisholm.
Thank you, Madam Chair. I just want to make sure I understand. So right now, the waiver is capped at 7,500. And if this bill passes, there'd be an additional 600. But we have 21,000 people on currently waiting. Is that correct?
Yeah, there's a registry, or we call it the wait list, and there's about 21,000 individuals on this wait list. And they stay on the wait list until they get an invitation from the department to apply for the waiver. And then after that process is done, it determines, okay, is this individual in fact eligible for the program? But because of the time it's been taking for individuals to get into the waiver, people sign up ahead of time, or they sign up and they're in urgent need, but they're getting lost in this shuffle of 21,000. The cap of 7,500, when the program was first instituted or put into law, the 7,500 was a cap. We're not going to have more than that, number of people served on the waiver. My understanding is the state has never even come close to that. Right now, I think there's maybe a little over 5,100 approved slots through an agreement between the state and CMS. So even there, we're not fulfilling or coming close to that number, that 7,500 number. And we also have not all of those 5,100 slots are filled. So there's a lot of numbers and slots and that kind of fluctuate over time. But we want to see a clear, let's get to the 7,500, let's fill those slots, let's through the 600 a month waiver applications or invitations. Let's see us whittle this population down to where we know what the true need is. It's not going to be 21,000 people. Hilltop did a study a year ago, and they looked at some the rate of return and how many people, when they're invited to apply, how many actually qualify to get onto the waiver, and that number is probably closer to 3,300. But it's really time to just drill down and let's get the people who need the services, and let's not let them languish on a waiting list. Madam Chair,
if I can follow up with one quick.
Absolutely.
Because I'm looking at the math. So if it's 600 per month, I guess that's where this number is kind of driving towards. That'd be 7,200 in a year, theoretically, if you do the math correct. I'm assuming that because 600 is an odd number, and I was just trying to figure out who came up with that number, and do we have the capacity to look at that many applications?
So why don't I allow Delegate Collison, whose bill this is in the House, to address those questions? Is that okay, Delegate Chisholm?
That'd be outstanding.
Thank you so much. I appreciate you. Go ahead, Delegate Collison.
Thank you very much, Madam Vice Chair. And thank you for the question, Delegate. So the 600 number was a sort of an agreement that we made 2 years ago with the department to try to whittle down the list, but it was really looking at potentially over three, whittling down the list over 3 years. They haven't had a lot of success with whittling down the list at all. In fact, the registry has actually gotten longer instead of shorter. The 600 is simply the number of letters that they send out per month. They only get, in general, about 120 responses back. And out of those 120, you've got a much smaller number of people who actually qualify. So in terms of, the general theory right now is that of the 21,000, we probably have somewhere between 2,500 and 3,000 people who would qualify for the waiver. But we have empty slots. I've done this bill now for 4 years. This is the 4th year that I've done it. But I happen to know that this bill has been around for over a decade. And it's just been, you asked the right question about capacity in terms of MDH. And we think that, it's not just, I met with the secretary and his team in October. It's not necessarily about capacity because they've been provided with 4 additional pins to do this work in last year's budget, which they didn't use. So we need to make sure that they fill the positions that allow them to really follow up on the letters that they send out and then the responses that they get from people who are there. So, and I believe there's an additional number of pins in this year's budget to address it as well. So, so then the governor has already, in addition, has put money in for additional slots. But in the 4 years that I have been a part of this effort, the number of slots being used has only gone up a few hundred. And in fact, in the last year, it went down 100. So we have available slots for people who are on Medicaid and Medicare to be receiving in-home care instead of going to a nursing home. And this is a program that is matched by the federal government. So we need to take advantage of those slots for our folks. Our seniors are really looking forward to this.
Thank you for that. That was very helpful. And I understand it much better now. Thank you. Thank you,
My
Madam Chair.
pleasure. My pleasure. Delegate Lewis.
Thank you, Madam Chair. And thank you to the bill sponsor. I wanted to mention that my mother was on this waiting list for almost 4 years and she died. And a few months after she passed away, we got a letter inviting her to participate. So I think this is really important. I know we're not the only family who was affected that way. So I just wanted to say that I'll be voting on this bill whenever we get to it.
Thank you. The department, not to put you on the spot, do you want to be heard? Actually, 1 second before we do that, Delegate Riley.
Thank you, Madam Chair. Yeah, I was actually going to ask, do we have, because any opposition on this bill was from the Department of Health. Have
It's
they?
because, yeah, they're here, so I'm going to
Okay,
ask
I'll
them.
wait then. Thank you.
Thank you. And I know it's because of the money.
Okay.
Basically like all the other bills. But I'll let them address it because I think Delegate Riley, it's a good question since they're here. Delegate, I'm sorry, Heather Scheck, will you be so kind and address the delegate's wonderful question?
Sure. Thank you, Chairman Pena-Melnick, and thank you for the question, Delegate Riley. The Vice Chair is absolutely correct. It was, we submitted opposition on the basis of just the cost. It is a large fiscal impact. I did want to there are a few things or a few comments made, and I just want to provide a little bit more information. One of the big challenges with the wait list is that it is just that it's not a registry. It's not, it's anyone can sign up to participate or to get enrolled on and get on the wait list. I mean, it does not necessarily mean that they're eligible. And I can't remember if it was Mr. Shattuck or Delegate Cullison, the sponsor, that mentioned this, but only based on historical experience, only about 14% of the people on the list are eligible. And one of the challenges is that when someone gets on the list and they're found to not be eligible, if they get an invitation under the federal law, we can't remove them from the list. And that's why we keep seeing the wait list grow, because under the federal law, you have to provide options for services. And so that's something that we're kind of coming up against. And that's why I think, we keep seeing the wait list grow. And another thing is, we did, I think it was Mr. Shattuck that referenced the Hilltop analysis. And I did just want to point out that of the 3,000 about folks that are on the wait list and eligible, there's 3 criteria that they need to meet. Only about 3% of those folks had a nursing facility stay while they were on the wait list. And so I just want to kind of highlight that it's not, we're not seeing people or the elderly population languishing in the nursing home waiting for this. It was only about 3%. And that I say only, but any percent that we can avoid, obviously we want to. I had one other point, but I lost it. So I will stop there.
So my question to you is, okay, you have a registry that you can remove people, but we know that, like Delegate Lewis's mom, right? They waited for a year and died. We know that people are dying, waiting for it. And we know that you had 2 pins that were not used. And in this budget, you have additional pins. So we need the bodies to go through those letters that you get back to get to the point of who actually qualifies, right? So what will the department do to get this done? Because I know we have had this conversation before. I have had it with the secretary before, right in the conference room. I remember having it.
Yeah, thank you. So we are actively trying to fill those pins. Pins are not people, unfortunately. And so we are trying to fill those. And I actually had a meeting with Senator Zucker, because I believe he's the sponsor of the crossfile. And we were discussing, and that is, to your point, Vice Chair, I think you bring up a good point, is that going through and cleaning up the list. Something as simple as who has passed away, who has moved out of state, who
That's
should,
right.
and so that's one thing that the department will be working on.
Yeah. So thank you. And Senator Kelly actually put it in, but Senator Zucker,
okay.
I know, is very interested in it, in those wait lists, to try to give you the resources, because there's more pins so that you can get it done. And I understand it. And thank you so much for giving us your answer. Which really appreciate it. Are there any other questions or concern? Delegate Johnson.
Thank you, Madam Chairman. And for Heather, is there no cleaning up of the list going on right now?
Delegate, that's a great question, and I don't know. I will find out for you. But I don't know the answer to that.
All right, thank you. Thank you, Madam Chair.
My pleasure. Delegate Hill.
Thank you, Madam Chair. And actually, Madam Chair, you had asked several of my questions, but Heather, here's my confusion. The pins were given, I think, 1 or 2 years ago. They haven't been filled. You're not sure if the wait list is being cleaned up, if it's being purged on a regular basis. So when we pass this bill, which I'm pretty sure we will, I'm not clear on what the department's going to do differently. And I'd like you to tell me what you guys are going to do differently, because you haven't figured out how to make a break on this problem. 3% of several thousand, still a lot more than 600 people. So it seems like what you're saying is you guys just can't figure out how to do better. Am I hearing that right?
Well, I think with the increase, if and when this bill passes, there will be, the number of applications that are sent out will be doubled. And so we're hoping that will give us a better rate of return on the applications to move through the list more quickly. As far as doing better filling the slots. I know that our HR personnel, we're hiring, I think LinkedIn folks, and we're working on the HR, the recruitment front, to try and get more people in. I think you had a second part of your question. And certainly, as I just said, we will, if the unit is not purging the list, we will certainly, that will be something that we are going to do and maybe do more frequently.
All right, thank you.
Delegate Collison.
Thank you, Madam Chair. So I guess one of the things that I would recommend, once we get staffed, is to look at what other states are doing. This long registry doesn't exist in other states. So they're using a program that actually helps them to keep, people up to date. So, I'm hopeful that with the extra pins and the impetus of this bill, we'll be able to figure out how to do it in a way that will be much more efficient for to get folks into the program.
Delegate Riley.
Thank you, Madam Chair. Yes, so I have a question then. Okay, so currently we're not cleaning up the list. We have a large list of what, 21,000? 21,000. So this bill will have the department, which adds to the fiscal note, is making the department to send out 600 letters to individuals saying, hey, have you filled out the waiver? You still need the waiver, fill out it, send it in or what have you, whatever. And then, but since we're not cleaning the list, those 600 people that we're sending it to off of the list could be uneligible again. And that's a lot of money to send to folks that are uneligible. So wouldn't it make sense to clean the list up first and then start this process?
Thank you, Delegate. And to be clear, I don't know if we're not cleaning lists. I have to follow up on that and find out for sure. But to your point, yes, if it's not being cleaned, that should absolutely, we should be scrubbing it. That should be one of the first things we do. And I will say, it's not, so previously the department, it was on the wait list, it was a first come, first serve, and that's how we would send out the applications. And now there's a screening process. So once someone does get on the wait list, there's, they run an algorithm. And so the highest risk needs folks on the list, 80% of the applications that go out each month go to the highest risk group. And then the other 20% go on a first come, first serve basis. Since those folks have been on the wait list, we didn't want to completely disregard that.
Okay, so somehow before we send out, because it's a good idea, to notify these folks, so that we can fill the positions of the waivers, because that's why we have the program. But is there any way that we can be, that we could put in here the 600 individuals that are getting this? Is there any way of us knowing that they would possibly be in that group of people that could really use this service? Otherwise, it's a waste. I don't know.
Yeah, so we don't get the 3 areas of eligibility are financial, medical, and I'm blanking on the third one, but we don't get that information back until they return the application.
Gotcha.
Yeah, so that's,
I knew there was a glitch there somewhere. Yeah, because it seems kind of odd. Because your percentages, your 3%, your 14% was, that's extremely low for us to be spending this type of money, to folks. I wish there was a better way that we could come up, with a situation to where we can know more information and then, or send it out through the nursing homes or something, and maybe not by the department. I don't know, maybe Delegate Collison has an idea. Thank you.
Delegate Collison, I was going to pick on you, actually call on you to address Delegate Riley's question, but because we've been here before, right? So we can't keep passing the ball. So can you address why we need to do this?
Well, in terms of why we need to do it, it's we can actually save money ultimately by putting people into this waiver. So even if it's 3% of the people that are going into nursing homes, a certain percentage of that may not need that. if they were able to get this waiver in time. So right now, the state is paying for that percentage of people in nursing homes, which is about 3 times more than it would be for in-home services. Plus, people want to be able to age in place. The increased cost is not the administration necessarily of mailing out those letters. It is if you get people into the waiver, there's an upfront cost of putting people into those slots. Right now, those slots are sitting vacant. And so no money is being spent on those slots. So what you see in the fiscal note is the cost of putting them into the slots themselves. But I would add that, as I said in my testimony in the hearing, when I first did the bill 4 years ago, the fiscal note was $70 million. This year, it's 1.6 million. So some different kinds of calculations have gone on because we've been working intently to try to figure this out. So that the cost right now, I mean, it's still a significant amount of money. I don't want to say that it isn't, but it will do so much good for 7,500 Marylanders that and I think the return on investment that Dan Shattuck spoke to with respect to the money that we saved. The very first fiscal note I had said that we'd save like $400 million a year just by filling those slots. But again, those numbers are all in the first iteration. We now have very different numbers. Does that help, Delegate?
Yes. Delegate Riley, do you have a follow-up? No? Okay. And as Heather Scheck said, that passing this bill will make them go through the list quicker, right? Because they're going to have to apply for the waiver. They're going to have to try to fill those pins and make it a priority, because we've been here before and it just has not been done at all. So that being said, any other questions or concerns? And again, this is for the very vulnerable people in our society. Any questions from anyone else? Okay, that being said, there are no amendments on this bill, correct?
Correct, no amendments.
Okay, so may I have a motion on the
Move the
bill?
bill.
May I have a second?
Second.
Okay, any questions or concern on the bill? Okay, all those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes unanimous. On the House bill, may I have a motion on the amendment, please? It will reflect the Senate bill. All right, any discussion? It's been moved in second. Any discussion on the amendments that are the same one that we just voted on the Senate bill? Seeing none, on the House bill as amended.
Move the bill as amended.
May I have a second? It's been moved in second. Any discussion? All those in favor say aye.
Aye.
Any opposition to this bill? Seeing none, is unanimous. Thank you, Heather. Thank you, everyone, for the discussion.
Madam Chair,
Yes.
since the House bill had an amendment, is it possible to request or consider sponsor amendment?
But we'll do that in the whole committee.
Thank you.
Thank you. Thank you so much. Good question. It is a good one to be on. House Bill 297 does have an amendment. It passed the Senate 47-0, and it's House Bill 297, Senate Bill 3, Facilities, Disabilities, Juvenile Behavioral Health and Healthcare, Children and Community Relations Plan. Erin, can you tell us what it does, please?
Yeah, and there is a reprint of this bill in pages 8 through 12 of your packet. The bill requires each state residential center to establish and implement a safety plan and revise the plan not less than every 5 years. Also, a state residential center may implement a safety or emergency plan established for another purpose. In addition, each application for certificate of approval for a private group home submitted to MDH must include a statement that the applicant will establish and implement a safety plan or implement a safety or emergency plan established for another purpose. Also, a facility that's regulated by MDH under Title IX of the Health General article that was in operation on or before September 30th, 2021, must submit a safety plan by October 1st, 2023. And each facility must revise that safety plan not less than every 5 years. Finally, the Department of Juvenile Services must adopt regulations that require each juvenile care facility to establish and implement a safety plan or implement a safety or emergency plan established for another purpose. In your packet, there is on handwritten page 10, there is an amendment that Senator Carter offered during the bill hearing in the House that if you look at the bottom of the handwritten page 10, that would strike language that would have required behavioral health programs to include in their safety plan a statement certifying compliance with the National Fire Protection Association 101 Life Safety Code and the National Fire Protection Association 99 Healthcare Facilities Code.
Okay. Are there any advocates that would like to be heard on this bill, on House Bill 297, Senate Bill 3? Okay, 1 second. I see Lori Doyle.
Thank you, Madam Chair. Just wanted to speak up on behalf of the amendments that the senator proposed, striking that language. We think that's extremely important to the bill. All of our behavioral health programs have to meet very strict fire and safety codes, not only local and state codes, but also accreditation requirements. And we think that that puts us at a significant disadvantage to require things that are not required of other entities that have to meet significant and similar fire codes. So we appreciate the senator striking that language.
Okay, I have Delegate Hill.
Thank you, Madam Chair. Lori, I'm confused. For exactly that reason, you're saying that it's that with the language, there's an uneven application, and it looks to me like without the language, there's no fire code for anyone. And I agree, it shouldn't be just you, it should be all the facilities. So I'm confused here, but why this wasn't added to everyone, or I'm confused.
Thank you, Delegate. I'm assuming all of the others as well. I can only speak to behavioral health programs. We already have to meet very strict fire safety codes. That's local codes, that's anything state codes, accreditation codes, internal and external inspections. So we meet a very high standard of fire safety now that includes fire drills that occur on every shift. It's very, very significant. So these additional things are on top of what is already required of us. And again, these specific additions in the bill pertain only to behavioral health programs.
And are they additional, or they're just explicitly stating what you already have to do by complying with the local codes?
They are additional because a lot of what is in those fire inspection, the added language is really about a physical plant. We already have to meet, sprinklers, all of those things. So there are additional things that would be required that would be costly to do and really unnecessary because of the strict standards that we're already held to.
So those are what, new sprinkler systems or something? I mean,
it's all kinds of things. It's quite a lot of stuff. You have to weed through all of those codes to get to all of it. It's very extensive, and it would be quite a burden on our providers to have to meet that, and unnecessarily because of what we already have to meet.
All right, thank you.
Thank you.
Delegate Rosenberg.
Thank you, Madam Chair. Lori Doyle has, I think, more than adequately answered the concern, the legitimate concern of Delegate Hill. Withdrawing or striking the amendment is something that all the parties involved, to the best of my knowledge, support, because it was added in the Senate during their consideration of the bill in committee, and now the sponsor and the entity that the lobbyist for the entity that sought the amendment has now withdrawn its support. So I'm very comfortable, and I think it's good legislation with this change.
Delegate Shalega.
Can you tell me why we're striking that if you're already doing it? I must have missed that.
It goes beyond what we're doing. And so there are additional potential facility applications and requirements beyond what we do. But what we do is already meeting the fire and fire safety codes in our state and our local jurisdictions. We have multiple inspections by all kinds of entities going through our properties and making sure they meet the fire safety codes. So we are saying that to put providers under additional requirements that are unnecessary is not only expensive, but in this case, particularly, we think it's singling out one group of providers that shouldn't be, singled out. It's just an unnecessary addition. And the further thing is the Senate put this on. We had no opportunity. This did not come up in written or oral testimony. It did not come up during the voting session, and there it was on the bill. We never had an opportunity to discuss it with the sponsor. And so when we did have a chance afterwards to educate, the sponsor and the proponents on what we already have to do, they said, oh, we didn't understand that. And so they decided to withdraw the language.
Okay, and I have another question. And Sandy, I like your little emoji, your surprised face.
It's gone.
I'm just ribbing you. Okay, so back to the bill. My question on the bill is, what is it for another purpose? Why are we giving it another purpose? Emergency plan established for the private group home for another purpose. What's the other purpose?
It could be that they already have that requirement. I don't know specifically. But we
One
don't want to
second.
remember, we
Delegate
potentially,
Rosenberg. Let me
Yes.
see if Aaron knows the answer. Aaron, do you?
Sorry.
I would think it's
Sorry.
probably like if they had to already do it for accreditation purposes. I would think that would be an example.
We're not giving the group home another purpose?
No,
We're
no,
giving-
it's the safety plan. It's referring to the requirement to have a safety plan or an emergency.
Okay.
That
And then-
would be for the other purpose.
And I remember speaking, we've had this similar issue before us before. Is this the one that we made sure we included a community notification of the community? Is that in here, Aaron?
That's different bills.
Okay, so this bill is simply requiring
safety
them
plan.
to have a safety plan.
Correct.
And are we going to make sure the neighborhood knows about the safety plan?
That's not part of this bill.
Why wouldn't we do that? If it's a juvenile care facility, it could be a group home in a community that has an active community association. Wouldn't we want them to, because I think we made them have some kind of contact with the community in the past. Why wouldn't we make sure that they continue to share their safety plan with the community?
Sorry,
That was-
Doyle.
Thank you, Madam Chair. I will say that the bill as originally passed a couple of years ago does require those entities that accrediting bodies require community relations plans to have those plans in place. So that's already part of the bill that passed a couple of years ago, Senator McCrae's bill.
So would the community then also know about this safety plan?
The safety plans are to be registered with the department at the time of licensure or relicensure.
So would they be public?
That is a good question. I don't know if what's submitted to the department is public or not.
I would think if we don't want to make them quote public for, some particular reason, I would assume that we would want to make sure that we revisit the community, ensuring that they know of the safety plan, because they should be in partnership with the safety plan. If there's a problem at the juvenile facility, that's a group home in a community, I'm assuming you want to partner with the community in that. So, if something happened, they would know, what the proper safety plan actions are. Is that true?
Probably. I mean, the safety plans are really very much about how, what happens if there is a fire? What happens if there is a tornado or a hurricane? There's all kinds of contingencies that we have to have safety plans for. And so to the extent that we do these fire drills and the safety drills, evacuations, I don't know that the community would necessarily gain anything by having copies of those safety plans. Now, the community relations plans, I think, may be something a bit different because that's how the entity plans to work in the community and involve the community and inform the community. So that may be getting more to what you're thinking about, Delegate.
Yeah, I guess I'm also thinking, what if there's an intruder? Would that be part of the safety plan? And in which case, would the community need to know what the plan was?
I honestly can't, just having been involved with the drafting of safety plans for my organizations when I was a COO, I honestly can't think of any of those that would be of interest, frankly, to the community. But I do believe the community relations plan would be of interest.
In the community relations plan, we passed Senator McCrae's bill that requires that, because I remember putting in that language in there.
Would we want to make this available to them if they wanted to see it? I mean, would that be applicable where we could say if the community relations plan, they could,
well, let's ask the Department of Health if is that a problem? Because it has to be submitted to them, right?
Yes,
so Heather.
Yes, let's hear Heather.
Sure. So they're under the Public Information Act, they would be available unless there was something, I'm thinking like hospitals, a lot of hospitals have safety plans. And if it has to do with criminal activity, threats, if there's anything in the safety plan that addresses how to handle those, then that part is not public for the obvious reasons that could put the safety, if you give a bad guy your safety plan, then they could know how to get around it. But portions of the safety plan, I would be public.
Okay. All right. Thank you, Heather.
Sure.
Thank you. So under the Public Information Act, Heather, they can request it and you'll be able to redact what's not out there for public consumption, correct?
Correct.
Thank you. Thank you, Delegate Shalega. Robin Elliott has been holding for a while. So why don't you go ahead, Robin?
I will be very quick. Robin Elliott, I am here on behalf of Ann Seacott, who I think might have just hopped on. But just a point of clarification on those safety standards, why they are challenging for community-based providers is that they're really written for facilities that have a lot of medical equipment. So it's about, for instance, the width of hallways and to make sure you could fit 2 hospital gurneys down a hallway in order to evacuate a facility. And so that's really the primary reason why those safety standards aren't particularly appropriate for the types of facilities we're talking about now. So just wanted to add that information.
Okay, Delegate Hill. Thank you, Robin.
Thank you. I'm sorry to come back for the second bite, but in the discussion that we just heard, it reminded me of when we were doing some of the school evacuation and safety plans and discovered that the schools, when they had students who were in wheelchairs and on second floors, the plans often said that they were to wait until fire and rescue came. And we had to pass legislation, I think statewide, but it might have just been in our counties, requiring that they have the devices available to evacuate immobile people. And I don't see that explicitly in here. So I'm going to ask Heather if it is understood when you all approve those plans that this bill will require, that it will be looking to assure that there are appropriate evacuation processes and equipment in place for people who cannot be evacuated under their own ambulatory efforts, or if we don't put that in explicitly, could they have plans approved that simply say those people have to wait until somebody comes in to get them out?
Yeah, so thank you, Delegate, for that question. I think the specifics will be done via regulations. And so certainly we could write that into the regulations that would have to be part of their safety plan.
Okay. And would you all, if we don't put it in here, if we don't amend it into the bill, would that be something that you all would agree to do?
Certainly, sure.
Okay, Madam Chair, I'm done. If that's comfortable for the subcommittee.
Yes, thank you. Thank you very much. Are there any other questions regarding this bill and the amendments? Seeing none. On the bill, let's take the House bill first. Actually, we went through the Senate bill, so let's do the Senate bill. On the Senate bill as amended, may I have a vote, please?
Madam Chair, I believe there
Motion.
needs to be an amendment offered to take out the language that.
Aaron, am I right?
Yeah, that's the bill before you has that amendment on the reprint on page 10. So you would have to vote on the amendment.
Okay, so on the amendment,
amended.
as amended, may I have a motion, please?
So moved.
May I have a second?
Second.
It's been moved in second. Any questions or concerns?
Yeah, are we voting on the bill as amended or the amendment striking the fire stuff?
You need to do both. So you need to vote on the amendment, striking
First,
the fire. Yeah.
and then secondly, okay, thank you.
So on the amendment, we're voting first. Striking the fire, right, Aaron?
Correct.
All right, it's been moved in second. Any concerns? Seeing none. All those in favor say aye.
Aye.
Okay, any opposition? Seeing none on the bill as, do we go on to the bill as amended?
Now you
Aaron?
need the bill is amended, correct?
The bill as amended, may I have a motion, please?
So moved.
May I have a
Second.
second? It's been moved in second. Any questions or concerns? Seeing none, all those in favor say aye. Any
Aye.
opposition? Seeing none. So Aaron, I take now which one?
So now you would do House Bill 297 to be amended in the same posture as Senate Bill 3.
Okay, so as you just heard, House Bill 297 to be amended in the same posture as
So moved.
the Senate Bill 3 is been
Second.
moved. May I have a second? Any questions or concern on this bill? Seeing none, all those in favor say aye. Any opposed? Is unanimous. Both bill pass. Thank you. So now we have House Bill 786, Senate Bill 568. It passed the Senate 46-0. Health records and reporting of overdoses, limitations on use in criminal investigation or prosecution. The last time we were here, Delegate Shaleka, you had a question about whether the bill was needed. We requested an AG letter, and the AG letter actually says that it is needed. Aaron, will you please tell us what the bill does and discuss the AG letter, and then we'll go into discussions.
There is a copy of the bill in pages 16 through 18 of your packet. The bill prohibits overdose information reported by an emergency medical services provider or by MIMS from being obtained by a law enforcement officer as part of a criminal investigation or prosecution. The requirement that a healthcare provider disclose a medical record without the authorization of a person in interest to grand juries, prosecution agencies, or law enforcement agencies or their agents or employees to further an investigation or prosecution pursuant to a compulsory process is subject to the limitations on patient overdose information reported by an EMS provider or MIMS being used for or obtained by law enforcement officer as part of a criminal investigation or prosecution. As Delegate Pena-Melnick mentioned, it was probably about a month ago that you all discussed the House bill that Delegate Shaleka had requested AG advice on whether the bill was necessary, and we did get a letter saying that yes, indeed, the bill is necessary to provide clarification that law enforcement could not request this information directly from EMS providers.
Does anyone want to be heard on this bill from the advocacy community? Okay, Ms. Mehu.
Madam Chair, I just wanted to note that this is an important bill. We're glad to hear that the AG's letter did clarify that it helps to close the loophole, and we would simply just ask for you to put bill in the same forms with that amendment we had sought in order to ensure that, as the AG letter noted, that the loophole was addressed. Thank you.
Okay, great. Are there any questions regarding Senate Bill 568 or concerns? Seeing none, may I have a motion, please? There are no amendments on that bill, correct, Erin?
Correct, no amendments.
Okay, may I have a motion? It's been moved. May I have a second?
Second.
Come on, guys, let's get with it. It's been moved and second. Any questions? None. All those in favor say aye. Any opposed? Seeing none, the bill passes. On House Bill 786. May I have a motion, please, in the same
The bill,
posture?
move the House bill.
It's been moved
Second.
and second. Any questions or concerns? Seeing none, all those in favor say aye.
Aye.
Any opposed? The bill passes unanimous. They're both in the same posture. Okay? We have House Bill 1005. And it's Maryland Medical Assistance Program, Community Violence Prevention Services. It passed the Senate 47-0, and the Senate cross is 350. Erin, can you discuss House Bill 1005? The Senate is in rules, but we have House Bill 1005 in front of us now. So can you please tell us what the bill does?
Yep. There is not a copy of this bill in this packet because there weren't any amendments, but you can pull up a copy on the website. The bill requires Medicaid, subject to federal approval and the limitations of the state budget, to provide community violence prevention services beginning July 1st, 2023. This bill is a little different than some of our other Medicaid bills in that it does require approval from CMS. And if the state does not get approval from CMS to provide the services under the bill, then the bill does not take effect. So that's clearly laid out in this bill.
Okay, thank you. I know some advocates and experts on here. They will address the committee. Will you be so kind? I know Delegate Smith, you're here. This is bill number 1005, House Bill 1005. Delegate Smith, why don't I let you go ahead first and then introduce the guest.
Thank you, Madam Chair. Hello, HGO Subcommittee. For House Bill 1005, we have Kyle Fisher here to add some additional expert feedback and context.
Mr. Fisher, good afternoon. Welcome to the Public Health Subcommittee.
Hi, thank you so much for having me. I greatly appreciate it. I'm Kyle Fisher. I've got a few different hats today. So I'm an emergency medicine physician. I work at University of Maryland downtown campus, Cap Region Hospital in Prince George's County and Bowie. And I helped launch the violence intervention program a few years ago out of Prince George's Hospital. But for the purposes of this hearing today, I'm the policy director for a national group called the Health Alliance for Violence Intervention. And we had worked with CMS and the Biden administration on the creation of this new Medicaid benefit. So I'm really excited to talk about this and answer any questions that you have. I know there's many.
Can you hear me? I can't hear you.
Oh, can you hear me now?
Yes.
Okay. Sorry, were you able to hear my brief introduction?
No, you said we did hear you that you worked with the federal administration and that this is a new Medicaid benefit, correct? That this waiver exists.
Correct, with a slight correction. Without getting too in the weeds, I see that the Department of Health is on the line. This can be done through a waiver, but it also doesn't have to be done from a waiver. The federal government has given you lots of leeway to do this with a simple state plan amendment. If you'd like to do a waiver, you're more than able to, but doing it without a waiver might be a little bit simpler, but you have the option.
Well, tell the committee why you think this bill is important.
Yeah, I'd love to. So this bill, I do think, is really incredibly important as we start to think about how to take care of violence as a public health issue. And when I say that, I mean not as throwing out buzzwords and saying, well, what does it mean to be a public health issue? I know you have all heard about different violence prevention strategies that exist in our state. We have Safe Streets in Baltimore. There are hostile-based violence intervention programs that I've been a part of out of Prince George's Hospital. Shock Trauma has one as well. And there's new programs out of Life Ridge and I believe Hopkins and a couple other programs are starting to think about that as well. And then there's ROCA as well that does community-based violence intervention by using kind of brain science, cognitive behavioral therapy to work with high-risk young boys and men, predominantly of color, to ensure that they don't get injured and they don't injure other people. And these programs are shown to work. They really do, but the funding has been boom or bust for a long time. And it's been very difficult to sustain these programs in a way that makes sense. So all of the programs have been kind of, they'll get grant funding one year and then maybe they don't get it the next. And they're constantly in the cycle of hiring people, training them up, and then losing people and then having to hire new people and, you know, going back and forth. And what this bill really does is it provides stability for running these programs and make sure that it's paid for as you do the work. And also, I know many of you know James Timpson from ROCA. He used to be at Safe Streets. When I was talking to JT about this a couple of weeks ago during the hearings, he said that one of the things that he thinks is really powerful about this is that it helps to decrease programs fighting against each other for the same pot of money. And it creates a standard that if you are qualified for this work, if you have trained and you are part of a certified program and you are doing good work, you'll get reimbursed for it rather than having to apply for the same grant funding in competition against everyone else, which I do think is really powerful.
Okay, great. And the community violence prevention services, they include peer support and counseling,
Absolutely.
mentorship, conflict mediation, crisis intervention, targeted case management referrals to certified or licensed healthcare professionals, or social services provider, patients education and screening services to victims of violence.
Absolutely.
So, all right. So it works as prevention, correct?
Yes. Yes.
All right. I have a couple of questions and thank you for being with us first I'm going to start with Delegate Robin Lewis. You're muted, Delegate Lewis.
Thank you so much, Madam Chair. It's feast or famine around here. Thank you.
It's okay.
I wanted to thank the bill sponsor for this fantastic bill. Very much needed and gets Maryland well positioned to take advantage of changes at the federal level of this new Biden initiative. It's great. One of the things I just want to make sure I understand how the bill works. Just checking it through, it looks like it funds violence prevention certification programs. And I'm just wondering if there is any, if it's just training providers or professionals in violence prevention, or if it's actually offering healthcare services. I just wanted to make sure we're clear on that. Thank you.
I think it's both. It's services and there's also a training program component to it.
And I suppose the details of that would be sorted out, or how?
Yeah, so this kind of lays the foundation, but yes, the details would be sorted out in the waiver application.
Wonderful. Thank you so much. Thank you, Madam Chair.
My pleasure. We have Delegate Johnson.
Thank you, Madam Chairman.
My pleasure.
My question is, you had made a statement, Mr. Fisher, about these are proven programs. Do you know where they've been proven? Do we have any data or stats on that? And it's because I noticed the letter by Johns Hopkins. It's peer recovery support services are delivered by people who have not only experienced mental health. When we're talking about mental health and peer recovery, are these certified or licensed folks, or are they just people who have experienced mental health issues themselves?
Great question.
Because if we're talking about treating mental health issues.
Yeah, so let me make sure that I get both parts of yours. So the first part about the data, we are actually very, very lucky that the first randomized control trial that was ever done, one of the landmark trials in the field, was done right here out of shock trauma by Dr. Carnell Cooper, that I know many of you know, who used to be at shock trauma and helped run Prince George's Hospital Center. In that trial, they had two groups of people, one that got the standard care and one that took part of the program. And it found that not only did it save lives as well, but in that group, for every 50 people that they took care of, it saved roughly, I've got the paper in front of me, $1.3 million in repeat hospitalizations. So by preventing people from getting injured again. And then also they looked at justice involvement and found that the patients that took part of this group were less likely to be incarcerated, which saved about $1 million for the 50 people that were in that group. So we have really great data on this. I'm more than happy to share. That was one of the first landmark trials. There's been many more since then. Happy to share that data with you as well. And then I believe the second part of your question was on the intersection with mental health, as well as the training and certification of the workers. You are absolutely correct. There's a tremendous amount of unmet mental health needs for people that have been exposed to violence and have been victims of violence as well. What we really sadly know, and we've known this for a long time, is that if you're someone that gets shot, whether or not it's overseas in Iraq and Afghanistan, or if it's on the streets here in Maryland, the human body does not make a distinction between where it happens. And post-traumatic stress disorder is exceedingly common when people are violently injured. It's approximately 80% of people that are injured like that will have some signs and symptoms of post-traumatic stress disorder. And we know that it's a group of individuals that aren't getting those services right now. They're very difficult to reach, which is one of the benefits of these types of strategies, because we can go out and find those people and make sure that those mental health needs are met. And who does that, which is the next part of your question. So these types of programs, whether or not it's ROCA or hospital-based violence intervention programs, they're designed so that they seek out members of the community that look like the members of their community, are from the neighborhoods, often have experience being injured themselves, and then they are trained up so that they know how to work in the hospitals and can do medical documentation, no HIPAA and mandatory reporting, and all of those really, really important things. So the HAVI, the Health Alliance for Violence Intervention, which Shock Trauma is one of the founding members of, we offer a national training and certification program that holds on to that, that many of the programs have gotten trained on here in Maryland as well. ROCA also has a training institute as well. So the HAVI isn't the only game in town.
A follow-up, Madam Chair?
Absolutely.
I have had several peer recovery programs pop up in my district. So I went to visit them. And a lot of them have no certified or licensed folks on site. So when the public goes to these programs, they think they're going for professional mental health treatment, but yet there's no certified or licensed people on the premises, but they are submitting claims to Medicaid. And my fear is that they're skimming money off Medicaid that could be going to licensed certified providers that could truly help folks with mental health issues. So do you have a comment on that?
Yeah, I understood. We want to make sure that Medicaid is, appropriately being used at the highest quality of care. what I'll say about this bill is that there is a certification requirement for the frontline workers. And there is a requirement that the individuals get referred to that by a licensed provider. So it does meet both of those concerns that you just raised.
All right, thank you. Thank you, Madam Chair.
My pleasure. We have next Delegate Shaliga.
Thank you. Is this, I see Monzi's in here. Is this part of Safe Streets, or would Safe Streets be a part of this?
So I know that the Safe Streets is very interested in this bill, and they have registered in favor. They sat next to me in the Senate hearing. They would like, and I've talked to Shante Jackson about this, they very much would like access to this. That said, they are in the process of making sure that they do some training up to make sure that they may have different tiers. I don't want to speak for them, but they do need to get some training and certification for, what would likely be a subset of their frontline workers to be accessible to that. As of today, if the program were to launch right at this moment, I don't believe that they would be billing Medicaid for it, but I know it is in their long-term plans and they'd like to.
Madam Chair, can I add additional context to that?
Sure.
Answer? Yeah, so the way Safe Streets is set up in Baltimore, there are different community partners that kind of sustain them. So it could be Catholic Charities, it could be Living Classrooms, and in Park Heights, I believe it's LifeBridge Health, which we all know is affiliated with Mount Sinai hospital system. So in that regard, it might be site specific who might be better prepared to take advantage of this opportunity, particular a location that is already affiliated with a community partner that's a hospital. So I just wanted to give a little context that all Safe Street sites don't have the same partners. So this bill would necessitate the Maryland Department of Health creating a certification that subsequently current Safe Streets personnel would be able to get trained under, and then thereby gain that certification that would be the same across the state.
And if I may, LifeBridge Health did submit a letter of support in this bill as well.
I would point to Maryland Psychological Association's testimony and their concerns, where they say that this specific section requires a clinician to make a risk assessment for potentially being a victim by an unknown person. Making risk assessment determinations for potential perpetrators of violence is difficult and limited by unpredictable dynamic. There are also, additional concerns that I think
I'm in the middle of subcommittee.
Are very, very valid concerns. Lastly, a concern, this is in the letter, that a reliance on these type of assessments without more clarity might make qualification for these important services be extremely limited. I also would like to note in the fiscal note, hold on, let me pull that up. I had it open right here. The Anne Arundel County Medical Association, I would just encourage all of the subcommittee members to really take a look at some of the valid concerns, but it talks about in the fiscal note, hold on, let me go there. I didn't print it out. I'm using online here that certified professionals means a prevention professional has completed a training, which the training hasn't been developed yet. Is that correct?
The Department of Health has to develop it.
Yeah, so we don't even have this training yet. I think there are some concerns, and my last concern would be this. I don't know if any of you watched the news, but there was a recent expose on Safe Streets where Fox 45 went and knocked on the doors of, I think, 4 or 5 locations of Safe Streets, and no one answered the door. They're currently in arrears for $1 million in back healthcare assessments that they owe to a local federally qualified health center. I have some serious concerns with this bill. if you're going to wrap it in with Safe Streets after watching this expose with some of the things going on with that program. Thank you.
Yeah, the bill doesn't say it's going to be wrapped up with Safe Street. It basically requires the Maryland Department of Health to seek a waiver so that they can get reimbursement. The state will pay certain amount, and the federal government will pay a certain amount. And we know that we hear.
I don't know if you heard. I asked Kyle Fisher about it, and he said that Safe Streets does want access to this program. So it's clearly there's clearly a nexus here, or I wouldn't have brought it up, Madam Vice Chair.
Yeah, I think you're right. I think many people are going to want to have access because violence is a problem, right? We hear it all the time on the House floor. We hear it all the time in the media. I mean, it was interesting to me was the Greater Baltimore letter. I don't know if you guys saw it. It's a business organization, right? What's the name of it? Greater Baltimore
Committee.
Yeah, and did you guys read their letter? And it's a pretty strong letter about why they thought that this bill was important as well. So I think that those are valid concerns, but the Department of Health is supposed to develop the program. I usually don't say much. I let the committee members ask the questions, but on this one, I spent the weekend reading about it. And I know that the Department of Health will be the one developing the program, the regulations, putting together the waiver and more of the details about it. So there's nothing set in stone. And I think that some of these issues can be addressed. And I guess the question for the committee is, do we try something new, right? Because what we have obviously is not working. Do we try to be creative with some guardrails, which I know it's popular words for us this session as well. So just food for thought. I'll let Delegate Riley, then Delegate Johnson. Go ahead, Delegate Riley. And I appreciate your questions, Delegate Shalega. Go ahead, Delegate Riley.
Thank you. Yeah, Delegate Shalega had mentioned the Anne Arundel County letter, so I was going to pull that out. So one of their points was, so some of these changes are going to be, or the challenges and the changes, is that we will be moving into non-clinical services into a fee that can be reimbursed by Medicaid. Is that correct under this bill? There are services currently that Medicaid does not cover that now we're going to cover. And how is that all going to work?
Yes.
Is that part of the process that you're saying that the health department is going to have to figure out how to do?
Yes. If the waiver is granted, the waiver will pay for these services.
Okay, and then on the fiscal note, it looks like it's going from 350,000 to 1 million. Is that every year once it hits the million?
I know Delegate Smith, you wanted to address the fiscal note, but Aaron, first, do you want to address the fiscal note? You're muted.
Sorry, I couldn't.
It's okay.
Unmute.
It's okay.
I'm not seeing where you're reading from. I'm sorry.
Yeah, I read in here, so I have a note when we had the bill hearing that currently the fiscal note cost is 350,000 and it will go to 1 million.
It says the fiscal note says, should a federal waiver be granted, Medicaid expenditure 60% federal funds, 40% general funds increased by an indeterminate amount beginning in FY 2023 as discussed below. And then it goes into page 3 of the fiscal note. And then it discusses if the Medicaid enrollees were treated in the hospital for intentional interpersonal injury, the average that it did, a year. But it says Medicaid advises that based on similar program proposed in California, services will be reimbursed at a rate of $750 per person, which assumes a rate of $15 per hour for 50 hours of services. And then it goes on to discuss assuming everyone will get it. Delegate Smith, would you like to address the fiscal note?
Yeah, absolutely. And I also invite Dr. Fisher to follow up if I miss anything. So that guesstimate is assuming that every person who's been a victim of violent crime, that has had that type of community violence experience would, one, if offered an opportunity, would avail themselves of those services that we're talking about, which is highly unlikely. 100% of anyone, doesn't see every service they're eligible for, but also there's not presently enough providers to even service that universe should there be 100% interest in all eligible and referred parties seeking the service. That's part of why part of this bill is about creating a credential, something that everyone can achieve that is recognized by the state, so that we can build capacity, so that we can provide more eligible people these services, so that we don't have kind of this ongoing back and forth where people are retaliating because they're never resolving the trauma. Sometimes 4 to 5 acts of violence later, it's really about something that happened years ago. It's not even about what happened amongst the last 2 people that are involved. So the number is a bit inflated within the fiscal note about if everyone eligible was referred and could access this, but they can't. But if they were, this would be this $4.2 million. But I think it's important to note that beyond that number being highly unattainable, just because there's not even capacity to provide services to that many people, 60% of that would actually be funded through Medicaid, which is federal dollars, and 40% by the state. So the state would not be assuming the total cost of that number presented. And also it's important to note that there would likely be net Medicaid savings for the state overall, because when you prevent the entire kind of flow of violence, when you short circuit it, that means there's other entitlements we're not paying down the line, because we've prevented other folks from being incarcerated, other people from being maimed or hurt seriously that also need to be treated using Medicaid dollars. So it's really about short-circuiting a system of violence by using public health interventions and ensuring that the referred party is referred by a licensed medical professional, and only after they're referred by that medical professional can they access this suite of other services that may be non-clinical in nature, but are recognized as being a complement to the services they were provided in a clinical setting. So Dr. Fisher, if I missed anything, I feel free to.
I think that really covers things really, really well. I've been involved with the rate setting and design in the state of Connecticut as they're lining this out. And, I think DLS did their best to try and make an estimate here based on, limited data. I think there's some areas where you can extrapolate from their what they've listed that is helpful. But I do think in their attempt to be really comprehensive, it's made it a bit more complicated, because they usually, actually in every dollar amount, they list both the federal and the state share in it. So for example, they do note that for every 500 people taken care of, that the Medicaid expenditures would be $375,000. And of the Maryland share, that means that for every 500 people that would get this, it would be $150,000. So very, cost effective in terms of Medicaid. We're not talking about expensive prescription drugs where, it's a couple $1,000s a month. It's very cheap services for the individual people. And to Delegate Smith's point, when Ledge Services did kind of the highest possible amount, they listed potentially 5,500 people that could get the services. We don't have the capacity to take care of that many people, even close. I did some back of the envelope math, and I think the best case scenario, and for me, the best case scenario is many people getting taken care of, regardless how much it would cost. The best case scenario I can get to is 1,000 people being taken care of. So that's 20% of what they listed. So, the fiscal note, and they do say this, they say this is for illustrative purposes only, and that they weren't able to come to an amount. But, when I run the math, I estimated, maybe $300,000 for it. And I'll also do want to add, I know that MDH is on here. The Hospital Association had some discussions with them, and I know that they had submitted estimates to Ledge Services, which were significantly lower than that top line dollar as well. If they want to comment on that, they're more than likely to.
Delegate Riley.
Thank you, Madam Chair. Yeah, I
My
raised
pleasure.
my hand down, but I had another question. So do we even know
Okay.
if Medicaid can actually reimburse these folks that we're certifying to, to give these services? Because I do know that our school psychologists currently in our schools, I tried to put a bill in last year to get reimbursement from Medicaid from some services from our school psychologists. And that is not one of the areas that they will, we can bill for here in Maryland, because they're strictly just certified and they're not clinical psychologists, master psychologists. So, do we have a letter from the AG to see if this is even possible?
Actually, this is the way the bill is drafted, if I may, and if I'm wrong, Delegate Smith or Dr. Fisher can correct me. The bill basically requires the Medicaid seek a waiver to be able to reimburse for these, services. So there is a program that was developed by the federal government that created a waiver for these kind of violence intervention. With this bill, Maryland Medicaid, if we passed it, we're telling them to apply for the waiver, right? And if the waiver is granted, then these services will be reimbursed. So what the bill is saying is Medicaid apply for the waiver, and if it's granted, then we can reimburse, but it says Department of Health, please create such a certification, right? For these programs so that we have these experts that can then bill. And in addition, the bill says that if the waiver is not granted, then this bill telling the department to create a certification in such a program is null and void. The bill will not take effect.
Okay. Thank you. Answer my
pleasure.
question.
My pleasure. Delegate Shalega.
Thanks for one more bite at the apple here.
Not a problem. This is the place.
Reading the bill, the training program is going to be 35 hours. Are there going to be any background checks for people that are going to do this training? And we need to make sure we're not calling them healthcare or mental health care professionals. I mean, 35 hours of training is what I was required for, a minimal trades program I took. And, I have serious concerns that we're conflating this with mental health care when the only training is 35 hours.
Delegate Hill, do you have something to say on this particular issue, or you have a question? Okay. Delegate Smith, who would like to address that?
Yeah, so I'm assuming that the Maryland Department of Health, as they're devising their eligibility for the credential, would be able to speak to if that would be something they would, do, as a standard practice. I don't know if Dr. Fisher has anything else to add.
Yeah, I can. That training and certification number comes out of what the national training is for violence prevention professionals, which includes that, but it also, before you're even allowed to take the training course, there is a certain degree, it's about 6 months of on-the-job experience before they add on that additional didactic and training and certification program as well. And it'd be up to the department to make that decision.
What does that 6 months on the job training look like?
So working with someone that's already in the field, either, for example, at the Shock Trauma Violence Intervention Program, the Prince George's Cap Region Violence Intervention Program, ROCA, working with someone that has the experience doing that work so that they are getting, frontline experience and know what the job entails, and then coming back to the classroom to make sure that they have the additional training about all the things that we talked about before.
Well, perhaps that should be in the bill then, because it just naked 35 hours without any other prereqs seems a little scant to me. Thank you.
Yeah, Heather Scheck, can I ask you a question about the background check? Is that usually in bills when we pass such, because we have passed in the past several bills that deal with you creating certain programs. Is the background check something that needs to be in, or something that you do by regulation? Do we need to be that prescriptive?
We can add that in the regulation. That doesn't need to be included in the legislation.
Okay, and regarding the 6 months training, should that be in the bill, Heather, or should that be by regulation?
I think that's a good question. I always, if that's something that this committee feels strongly about, that they want 100% included, I would include it in the legislation so that we all know that there's a regulation process that can be changed. So if that's something that is non-negotiable, I would put it in the legislation.
So it's a 6 months on the job training. Is that what you're envisioning, Delegate Szeliga?
I'm envisioning this bill being defeated. So no, I would say a year on the job training. I'm very concerned that we're going to pretend like these are healthcare professionals and that we're going to get Medicaid reimbursement for this program with the tiny amount of regulations that you're putting on it.
I think what we heard is that the national training for this program is 6 months on the month, 6 months training on the job and the 35 hours. And what we're hearing is that the federal government has created such a waiver for such a program that they would accept those qualifications, because we are asking the department to put in the waiver application. And if it's granted, it will have to meet the expectations of the federal government and the criteria. So it will either be granted or not. But we heard from Mr. Fisher that these are the numbers in the requirement. But we'll keep talking. I have Delegate Hill next, then Rosenberg, then Johnson, then Bagnall.
All right, thank you, Madam Chair. Delegate Smith, I'm not sure if this is for you or for the doctor, but there was a letter of information I'm trying to pull up now, I think from the psychiatrist, that raised some issues about the bill and the Maryland Psychological Association. And when I read the bill, I don't really see where they're in it, but I wanted to ask you or the doctor to address it. They say that it requires a clinician to make a risk assessment for potentially being a victim by an unknown person, and that this is sketchy at best, that those kinds of assessments have no predictive value. So I guess this is really for the doctor. And they also say these assessments will be completed by a licensed healthcare professional and does not specify what type of licensed healthcare providers. And doctor, since you are an emergency room physician, you talked about emergency room violence interventions. I assume what you're saying is this is not something for that you are anticipating psychologists, psychiatrists, or trained psychological specialists to be doing. Am I understanding correctly that this is other physicians and practitioners?
So yeah, it's the broader medical community is able to make this. With respect to the Psychological Association, I think they missed the boat a little bit on this and perhaps weren't aware of this type of programming. There are nearly 100 programs like this across the country. And this risk assessment that they're alluding to, we're not talking about doing an immediate extreme risk protection order or anything like that. This totally different issue than that. we know that if you have been violently injured, that based on that injury alone, there have been 19 different clinical trials that are published that by being injured alone, your risk of being injured again is about 1 in 3. So by that injury happening, that you are starting out at a risk that you do need services. So these programs that have been done nationwide, including in our own state, they're very highly protocolized. And we have decades-long programs here in the state alone, and that type of concern isn't really related to this type of program. Respectfully for the psychologists, I think they had something different in mind when they mentioned that.
Okay, and so that I'm clear, and the reason this is different from, say, the intervention programs that we see violence on the other side, this is focusing on people who are likely to be victims and trying to teach them how to engage in their community in a manner that makes them less likely to be victims, whereas Safe Streets is really geared towards people who are perhaps tending to be perpetrators and trying to teach them other coping mechanisms so that they are less likely to use that as an option for dealing with conflict. Is that a fair differentiation, or am I incorrect?
I think that's close. I always, struggle. We know that there can be kind of, sadly, someone that's been victimized is at risk of victimizing other people. So the Venn diagram isn't perfect, but this does explicitly focus on victims and making sure that they are decreasing their risk of being re-injured again. Because we know if we do nothing, which unfortunately is the standard of care in most of the country, the risk of that person dying is about 20%.
Oh, thank you. Thank you, Madam Chair.
We have Delegate Rosenberg, followed by Johnson, followed by Bagnall, followed by Chisholm.
Thank you, Madam Chair. It's almost in the form of a comment as a question, but isn't the procedure that this bill lays out, that is seeking the waiver and everything being contingent upon the waiver being granted, that is our standard operating procedure for the Medicaid program, is it not?
Correct.
Counsel?
Yes, you have to apply for the waiver, and this bill is very specific that if you do not get the waiver, that the provisions of the bill are null and void. So the federal government would have to approve the waiver.
Okay. Thank you.
Delegate Johnson.
Thank you, Madam Chairman. And whoever's best to answer the question. My issue is not with the program, not with getting a waiver. My issue is with misleading the public. So is it possible to have in the bill, on any signage or literature, that it's very clear that this is peer recovery and that folks do not think they're going to a licensed mental health doctor? Because in my visits to these peer recovery programs that have opened up in my district, it is very unclear what the public is walking into. And it's very misleading that they think they're going to a licensed mental health provider.
Madam Chair?
Yes.
Can I get a point of clarification? Because I'm not certain what, Delegate Johnson, are you talking about peer recovery for people with substance abuse disorders? Because I feel like you're conflating things that are not what my bill's about. So I just want to make sure I'm understanding your question.
I'm talking about anything that's peer recovery related, because when it's peer recovery, it's something totally different than a licensed professional with mental health, with mental issues, with substance abuse. It's different. So I just want to make sure the public understands what they're going to. Now, if we decide to get a waiver and pay for this out of Medicaid, that's fine. But the training is a little light, but I at least want the public to know that they're not going to a licensed medical individual, that it is peer recovery.
Well, Dr. Fisher, before you respond, I think this is a really important distinction, Delegate Johnson, that I really want to help you understand. You cannot access the services being provided in this bill unless you are referred by a medical professional. Like, you can't just get up and say, I want to go to this shock trauma devised, you cannot self-select to become a consumer of these services. You would have to be referred after you're in a setting where after you've been, a victim of community violence. Only then are you being referred to this as an opportunity to get assistance. And I think what's also really important to remember is this is a population that almost uniformly has zero access to mental health care. So they're not in the market actually for mental health care. They're being encouraged to gain some level of support for something otherwise they probably wouldn't even think to access. I mean, that's kind of the elephant in the room. Most mental health care providers are largely supporting people who are living a middle-class lifestyle. This is a population we're talking about that currently has very, very limited access to any type of support. And so I just want to make sure that that this isn't something you can elect to just go and get. You would have to be referred by a social worker or a mental health
door for the public.
Yeah, Dr. Fisher, please jump in. But I feel like
we're
talking about different
things. That's okay. You did it, Delegate. If it's not open door to the public, that cleared a lot of things up for me. Thank you.
Yeah, it's
Thank
not.
you,
You're welcome. It's not open to the public. It's a referral, but you have, for example, here, just so that the committee knows, the emergency physicians support this, the nurses support this, the professional counselors support it, the local board of the Greater Baltimore supports it, the hospitals support it. So it's as they said, a program. There are over 100 programs across the U.S. It's already being done. This is a way to try something different and to see if we can get reimbursed if it were approved. So just so that the committee knows the letters that were also in addition to what the ones that have been referenced in the file. And I think it's Delegate Bagnall, then Chisholm.
Thank you, Madam Chair. And I think we're close to getting the answer, but I just want to make sure that we're getting it on record. Dr. Fisher, you alluded to this, but Heather Scheck, if you could just confirm, non-clinical community peer-to-peer services are not unique to this bill, and we have them existing already in Maryland. So what we're talking about is a very specific type of peer-to-peer service, which is dedicated to violence prevention. Is that correct?
Yes, Delegate, that's absolutely correct.
Okay, thank you very much.
Delegate Chisholm.
Thank you, Madam Chair. And this is probably for Delegate Smith, because I'm taking this from your letter. I'm just trying to figure this out. So based on your letter, this is mostly focused on gun violence in Baltimore. I know there's other types of violence, but that's what we're looking at here. And I'm trying to just understand how it plays out. So we could have somebody, let's say a gang member shot, goes to the emergency room or shock trauma. Then an emergency physician would then refer them out, or their family was, I see you talk, I just don't quite understand the whole scope of this. Would the whole family then be eligible for some of these Medicaid service or these services, or just the
victim?
I guess the victim, because you correctly cite the number of shootings in Baltimore every year. And so I'm just trying to figure out who would be eligible. I know that an emergency room physician or a provider would have to make that recommendation, but I'm trying to wrap my head around how many people this would actually affect and how many people necessarily or unnecessarily. And then my follow-up question, and I know that on the 6 months training following somebody around, well, my concern would be who's training them for those 6 months, because if it's somebody that's not well qualified either, we just have unqualified training unqualified, which is a concern. If you can speak to those two things, that'd be great.
Of course, Delegate Chisholm, and also if I have a need for Dr. Fisher to jump in, if I'm missing anything, I just want beg your indulgence with that. So in terms of my written and oral testimony. Community violence can be, at the hands of a gun, but we have stabbings. And unfortunately, we have domestic incidents where sometimes there's not even a weapon. I mean, people unfortunately can engage in violence in a number of ways. So I don't want people to think that this is only, about gun violence. It's about violence in the community. Another thing I wanted to point out is that when we're analyzing through the Mayor's Office of Neighborhood Safety and Engagement, when we're analyzing kind of the patterns of violence, I think people will be surprised how often the context of like a gang is not what's driving a lot of crime the way you would think, because a lot of people are engaging in things that are really kind of personal to them. It's kind of like in a community, just because people live together and are experiencing trauma together does not make them like a member of like an organization or have certain affiliations, but just being in proximity to people being victimized can itself make you a victim, because now you're exposed, to so many unsettling things, be it in your home or in your community. So I wanted to kind of lift up that I do have meetings with the Baltimore Police Department pretty much every other week. And they were saying, this is a completely new world we're in, where a lot of stuff is just, my friend got hurt, now I'm mad, and I'm feeling like I need to do something with this. Just to be transparent, one of my interns last year, her boyfriend was murdered, and it wasn't really anything to do with him. It was something to do with other people that were close to him. So there are a lot of unintended consequences of unresolved trauma. And this is what this bill seeks to address by helping people to find a way to, in a healthy manner, channel all of the feelings, all of the discord, all the pressure, the PTSD, channel all of that into a healthy way of getting through grief and getting through trauma, versus creating an endless cycle that we see carry out in the press in ways that are just heartbreaking, and they seem self-perpetuating. This bill would allow someone to see if there were other people, perhaps in a home, others that are survivors of the violence, to gain access to these resources too, because they too could become a future perpetrator or a future victim if they do not know how to deal with kind of what they're going through. So I'll allow Dr. Fisher to jump in, but I think it's a real important question you asked, Delegate Chisholm, because it's not just the person who's shot that's a victim, right? It could be their child that's now a victim, of seeing their parent go through something like that, or another relative. So I do think we have to expand our notion of who victims are, sometimes in a more conscious way. And I challenge myself and all of us when we're talking about violence. It's not just the person, that was physically assaulted or who died. It's those who are in close proximity to them and who love them that are also impacted. So I really appreciate that question, Delegate.
Dr. Fisher, is there anything you would like to add?
Yeah, I think, it may help to just imagine how someone might get enrolled in a program like this. And just very briefly, say someone is injured, they go to the hospital. What happens is one of the frontline workers, like we're talking about, so I'm going to use David Ross from Shock Trauma as an example. David is actually one of the national trainers that trains people around the country. So David sees the patients as soon as physically possible. If it's in the emergency department, great. If they're too sick and they need to get admitted in the hospital, he'll see them in the hospital once they're a little bit more stable, and then brings up to the patient about the options of these services that are available to them. They do immediate crisis intervention to see if there's anything else that needs to happen in that particular moment. And then they create a needs assessment of what are all the things you need to be physically, mentally, socially healthy and happy moving forward, so that they can work with the patient over the next 6 to 12 months to make sure that all of those things to make a full psychological recovery, physical recovery, and decrease the chances of any re-injury happen. So when you think about it through how you get enrolled, you can imagine what the universe of how someone gets involved with a program like this.
Thank you. And Madam Chair, if I could ask a follow-up, since Delegate
Absolutely. This is the place. Yes.
Delegate Smith says something that piqued my interest. because I know that she works with the Baltimore City Police. Did they have any input? Because I looked in the committee testimony, I didn't see any committee testimony from them. If they were willing to submit testimony, or if you've ever gotten a response from them as to how they think the program would work, and were they in favor of it?
They did not go on the record here. This was definitely something I worked more closely with the Mayor's Office of Neighborhood Safety and Engagement. But I do want to be transparent. The Mayor's Office of Neighborhood Safety and Engagement works incredibly closely with BPD, and they are very much engaged with the work of ROCA and other related violence, community violence prevention organizations. They know that they cannot be everywhere. And they also do know that there are certain people that have certain access to folks that they don't have access to in ways that they do not. So they are definitely appreciative of any community-led initiative that expands their, kind of reach to be impactful. I actually am about to get on a call with BPD right when this ends, and they've never expressed any concerns about it. There's another bill they want to talk to me about.
Thank you, Madam Chair. Thank you, Delegate.
My pleasure, Delegate. I have Delegate Hill followed by Delegate Lewis.
Madam Chair, never mind. I think Doctor explained. I just wanted to focus on the language, because I think there was some confusion that the bill says that the prevention services includes referrals to other providers who are sort of social work providers, healthcare providers, patient education, screening services, conflict mediation, crisis intervention. And so these people are simply trained to understand what those various resources are and how to communicate with the people in the program to help them to be open to accessing. At least that's my understanding. And I guess that's a question for the doctor. Is that a fairly accurate assessment of the work that these specialists are doing?
Yeah, I think that's I like to think of these frontline workers as kind of guides in people's recovery through traumatic experiences, and they do the peer mentorship and help walk them through it and make sure that everything that they need to recover, be it case management, social work, mental health services, that they're getting people to those needs.
Any other questions, Delegate Hill? Okay. Delegate Lewis.
Thank you so much, Madam Chair, for the second bite at the apple. As I listened to the questions and deliberation, it occurred to me that this committee has been at the forefront of innovative approaches to holistic public health. It occurred to me, I remembered that, hang on. I just off the top of my head made a list of bills that we've introduced just in the last year that address public health approaches to violence prevention and holistic health. We passed a bill to create a commission on health equity, the Shirley Nathan Pulliam Act. That was HB 78 last year. We passed and that creates basically an advisory panel that will recommend approaches for improving public health, including violence prevention. It's in that bill. We passed the Health Equity Resource Act. That was HB 463 last year. That creates a grant program, which sets up a flow of resources that communities can benefit from to address all kinds of community problems, including violence prevention. And then we passed last year again, the Trauma Informed Care Act. We called that the Healing Maryland's Trauma Act. That was HB 548 last year. This committee passed all of these bills and they became law. The Trauma Informed Care Act trains state workers in agencies, public facing agencies, to learn how to deal with trauma. And all these bills are in law and they're happening. They became law and they're all underway right now. It seemed to me that the good delegates bill, the sponsor, her measure falls very much in line with legislation we've already passed and a commitment we've already made. I will also mention, thank you, Dr. Fisher, for that wonderful Medicaid, that CMS report you put in the chat. I've already printed it and read it. And this makes very clear that, in fact, the state of Maryland is right now, this very minute, spending Medicaid dollars on violence prevention. Medicaid plays an important role meeting the needs of those who have experienced violence and trauma because, I think as Delegate Smith said, this is a population unlikely to have private insurance and very likely to be exposed to all sorts of slings and arrows. And so I think given all of that, my question for the bill sponsor is, does it make sense as your bill in the context of all that we've already done and that we're already doing make sense for the state of Maryland?
Yes,
Thank you.
that's a complete sentence.
Okay, Delegate Hill, do you have another question? Your hand is up. Thank you. And Delegate Robin Lewis, your hand is up. Are you done? Okay. Are there any, one second, any other questions or concerns regarding this bill? I know I have allowed conversation for probably an hour, but I wanted, this is the place. Okay, seeing none, Delegate Hill moved the bill. Is there a second?
Second.
It's been moved and second. Any questions or concern on the bill? All right, seeing no questions, all those in favor say aye.
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 Any opposed, will you raise your hands? I have Delegate Shalega, Delegate Chisholm, and Delegate Riley. Anyone else? Okay. The bill passes, not unanimous, okay? Thank you for the discussion. This was really important. And I appreciate the experts and the Delegate Smith, for your time, and Heather Scheck for your insight as well. So now we have Senate Bill 168. It passed the Senate 43-2. And will you be so kind, Erin, and just tell us what the bill does?
This is a departmental bill that repeals the exemption from certain immunet requirements for a healthcare provider who administers vaccines in a nursing facility, an assisted living program, a continuing care retirement committee, or a medical daycare program. In addition, the bill alters the membership of and term limits for members of the statewide advisory council on immunizations.
Okay, Heather Scheck, will you be so kind and tell this committee why you want this bill?
Yes, thank you so much, Vice Chair. So the first thing, as Erin stated, that the bill does is it removes an exemption. Previously, several long-term care facilities were exempt from reporting data into the immunet system, and during COVID, it was very clearly illustrated that they could do it. It wasn't a huge burden on them, and the data is extremely important. It was especially important during COVID, and so this bill removes that exemption so that we can continue to gather that very important data. And then the second
exemption that it removes is from who? Please say it on the record.
Sure. It removes the exemption from nursing facilities, assisted living programs, continuing care retirement communities, and medical daycare programs.
To report the data, correct?
Correct. To report the data into the immunet system.
Okay, and we know that they did it during the last 2 years.
Correct. Yes.
Okay.
Yes. And it was very useful data for us. And then the second thing the bill does is it changes some of the, it modifies the members on the advisory commission. The commission was having a hard time filling certain seats. And so it removed some, it added term limits on 4 years for members. And then at the request of some of the advocates and stakeholders, it also added 2 specific members to the advisory commission. And as you stated, Chair Pena-Melnick, it did pass the Senate with a vote of 43-2.
Okay. So are there any questions or concerns? This is the time. Delegate Riley.
Thank you, Madam Chair. Yes, I have a question. Did you say daycares will now have to do that?
The adult medical
Adult,
daycares.
okay. I thought there was that. Okay. And then another question, didn't we have this in the House as well? House bill? I know it doesn't show cross file, but wasn't there a House bill?
No.
The departmental.
Not
Okay.
cross.
We did just have the hearing on it not too long
Okay.
ago, so that would be it.
All right, thank you.
Thank you for your questions, Delegate Riley. Are there any other questions? Seeing none, any concerns? All right, is there a motion on the bill?
Move the bill.
Is there a second?
Second.
It's been moved in second. Any questions or concerns? Seeing none. All those in favor say aye.
Aye.
Any opposed? Delegate Shalega is opposed to it. Delegate Shalega, you're opposed or you have a question?
I'm opposed.
Okay, all right. So is there a question that you want to address from the department?
Nope, thank you.
Okay, great. So there's one opposition, the rest in support of Senate Bill 168. Thank you. Next, we have Senate Bill 174.
This is also a departmental bill that extends the termination by 10 years from December 31st, 2022 to December 31st, 2032 of specified provisions related to the Mortality and Quality Review Committee, including that the committee must review specified aggregate incident data and include such data in its annual report. The committee must make findings and recommendations to MDH on system quality assurance needs. The Office of Healthcare Quality must provide the committee with specified data, and the Developmental Disabilities Administration must provide the committee's report to specified facilities and programs.
Okay, Heather, this bill passed the Senate 47-0. Tell us what was so convincing that you had a 47-0 over there. Tell us.
Thank you so much, Vice Chair. So just a little bit of background, what the MQRC does, they review all deaths and reportable incidents in programs and facilities licensed or operated by the Developmental Disabilities Administration and the Behavioral Health Administration. And the primary goal of the group is to identify patterns and systemic problems within those two administrations and the provider community. And then what we do with that information is take action and make recommendations on how to prevent those from occurring in the future. And really the overarching goal is just to improve the quality of care. There's a pretty lengthy process that it goes through. The incident gets reported, and then our Office of Healthcare Quality reviews and investigates, and then the case is presented to the MQRC. And what this bill simply does is just extends their authority to continue investigating these incidents for the next 10 years.
Okay. Are there any questions from the committee for Heather? Any concerns that you have that you'd like to ask her now? Okay, seeing none, there are no amendments on the bill. Is there a motion? It's been moved. May I have a second, please? It's been moved in second. Any questions or concerns? All those in favor say aye. Any opposition on this bill? I don't see any. It's unanimous. May I have, please, Senate Bill 186, Maryland AIDS Drug Assistance Program Fund. It passed the Senate 45-0. Will you tell us what the bill does, please? Erin.
This is also a departmental bill that establishes the Maryland AIDS Drug Assistance Program Fund to support the administration, operation, and activities of MADAP. I hope I'm saying that right, Heather. The MDH must administer the fund, which consists of rebates received by MDH from MADAP, money appropriated in the state budget to the fund, interest earnings of the fund, and any other money from any other source accepted for the benefit of the fund. MDH must deposit any rebates from a source other than a federal source received from MADAP into an account within the fund to be used only to fund state identified priorities for HIV prevention, surveillance, and care services. The fund may only be used to fund MADAP, MADAP Plus, and any other services to eligible individuals as authorized under Plan B of the federal Ryan White HIV/AIDS program.
Okay, Heather, you're on again.
Thank you so much.
My pleasure.
So MADAP stands for the Maryland AIDS Drug Assistance Program, and you had it right, Aaron. Good job. And what that program does is that it ensures that our Marylanders with HIV and AIDS have access to the medication.
Send out something about the.
Delegate Riley, we can hear you. It's okay. Go ahead.
Thank you.
I do it all the time. Go ahead.
It ensures that Marylanders living with HIV and AIDS have access to the medication that they need. The program pays for medications for eligible clients that don't have insurance, or it helps those that do have insurance by paying for certain copays and deductibles, just to provide access to that medication. And so the reason that we need this bill is to bring us in compliance with federal regulations. There was a 2020 Office of Legislative Audits review of our department pharmacy services, and it was discovered at that time that the department was not receiving interest earned on the MADAP rebate funds. And so what this bill does is it creates the fund in legislation for this money to go into, so that the department can then earn the interest on those rebate funds. And it was passed unanimously in the Senate.
Yes. We do have a question from Delegate Hill.
Real quick, Heather, just to be clear, so the fund itself was a non-interest bearing fund, or it was interest bearing, but it was set up in such a way that the state could not recover the interest?
It was a non-interest bearing fund. When it was originally set up, we didn't, it was set up so long ago that we didn't have those types of funds yet. So.
Okay, all right, thank you.
Sure.
So we didn't lose money, we just didn't get money that we could get if we set it up differently.
Absolutely correct.
Okay. Move the bill.
Okay, the bill has been moved.
Second.
Any questions or concern? I like that, Delegate Hill. Seeing none, all those in favor say aye.
Aye.
Any opposition? Seeing none, the bill passes unanimous. Okay, Heather, you're doing well here. Let's go on to 196. It passed the Senate 47-0. Let's see what you can do here. Erin, go ahead.
This is also a departmental bill that alters the requirements for the data-informed overdose risk mitigation report by removing and amending specified terminology. The bill extends the termination date for the report from July 31st, 2022 to July 31st, 2024. The bill also preserves the July 1st, 2022 termination date for section 1-224 of the health occupations article, which requires establishing a tip line for the reporting of licensed prescribers suspected of prescribing medication in violation of the health occupations article.
All right, Heather, you're on.
Thank you. So what this bill extends the department's ability to collect this data. We call it the DORM report, which is the Data Informed Overdose Risk Mitigation Initiative that was passed in 2018. And what it did was created risk profiles by linking overdose death records to certain systems level data sets. And it gives the department, and really OOCC, the Opioid Operational Command Center, is doing fantastic work with this data. And it helps them understand who is at risk for overdose so that we can identify and direct resources to those areas to better calibrate programs aimed at reducing the mortality and overdose. And so the OOCC has worked really closely with our Behavioral Health Administration, and extending the mandate for this report will just allow us to continue doing that really important work.
Are there any concerns from the committee regarding this data that is being collected from the department? Do you have any questions? Okay, seeing none, is being moved. Is there a second? Move in second. Any questions or concerns? Seeing none, all those in favor say aye. Any opposition to this bill? Seeing none, the bill passes unanimous. Heather, you're on, I'm sorry, Aaron, Senate Bill 200, Public Health Prescription Drug Monitoring Program, naloxone medication data. It passed the Senate 45-0. Go ahead.
This is also a departmental bill that requires the Prescription Drug Monitoring Program to monitor the dispensing of naloxone medication, establishes standards surrounding the disclosure of naloxone medication data, and generally applies the PDMP statute to naloxone medication data.
Heather.
Thank you so much. So this bill really is filling in an identified gap. The one thing I do want to point out is that all the data collected, it will require prescribers of naloxone to report this information to the PDMP, but it will be in a disaggregated fashion. So there is not any patient level data that will be collected. The bill also specifies that the data cannot be used for any purposes other than education. It cannot be used in police investigations. It cannot be used to prosecute someone. Law enforcement can't get it to increase surveillance in certain areas. So it's really utilized. What the PDMP will do with it is look at the data in an aggregate fashion, and then it will help us understand where, again, to direct our resources. If we're seeing hotspots that there are a lot of naloxone dispenses in a certain area, we can then deploy additional resources to that area to try and combat the opioid usage.
Okay, so to the committee members, are there any questions or concerns to Heather Scheck regarding the data that is being collected and its uses? Seeing none, is there a motion?
Move the bill.
Is there a second? It's been moved in second. Any questions? Any concerns? Seeing none, all those in favor say aye.
Aye.
Any opposition to this bill? It passes unanimous. Next, we have Senate Bill 394, Statewide Targeted Overdose Prevention Staff Act of 2022. It passed the Senate 45-0. Go ahead, Aaron. Can you describe the bill, please? And then Heather, I will ask you.
This is an administration bill that broadens existing requirements and protections relating to administration and provision of naloxone to encompass an opioid overdose reversal drug approved by the US FDA. The bill also allows for such reversal drugs to be offered to specified individuals free of charge by multiple providers, programs, and entities, which are generally required to establish protocols. The Maryland Department of Health must purchase and then provide FDA-approved opioid overdose reversal drugs at no cost to the entities who may provide the reversal drugs only if MDH provides them. The bill also authorizes a cardiac rescue technician, an emergency medical technician, or a paramedic while providing emergency medical services to offer an FDA-approved opioid overdose reversal drug to an individual who received treatments for a non-fatal drug overdose or was evaluated by a crisis evaluation team.
Chair Pena-Melnick, can I kick it over to Jake Whitaker? He's here from the governor's office. This is the administration bill.
Okay, and there is actually, before I go over to you, and thank you both for being with us. We appreciate you being here. The question I have, and there was an email that I sent regarding this bill that I know we sent to the department. And if you can address that email that was sent to the committee with concerns about this bill. I know we let you know ahead of time because I don't like to surprise anyone, and I wanted you to address us if that was really a concern. So good afternoon, Jake.
Hey, Madam Chair. I'd be happy to answer that question. I spoke to the advocate who wrote the email that you forwarded to me. Her concern was about the difference between dispense and make available. I think her specific concern was that by not including the word dispense, we weren't actually putting naloxone in the hands of folks who needed it. So I spoke to her that because the department's going to be providing the funding for the naloxone itself, they're going to be distributing the actual boxes of naloxone or in the future opioid reversal drugs. So it's not going to be like a situation where there's a voucher or a prescription where that individual needs to go from, for example, a homeless shelter to a pharmacy to get it. They'll be handing them out the naloxone. So I think once I clarified that with the stakeholder, I think we're good to go with the bill.
All right, can you tell us why we need this bill?
Yes, we found that one of the most effective ways to reverse an overdose is through the distribution of naloxone. We found that when we dramatically increased the saturation and distribution of this drug, we found a significant decrease in overdoses. I think also very importantly is that when we make this available, the individual who is at the risk of an overdose is more likely to be in contact with clinical services and other opioid treatment services. So we think in conjunction with those two, we can really reduce the amount of fatal overdoses that Marylanders experience.
Okay. Are there any questions? Actually, any of the advocates that like to be heard on this?
We appreciate the work that both the department and the administration, they worked really well with us to address the concerns in the bill. And we think it's a very good bill with the amendment.
Okay. Are there any questions from the committee members to the department regarding this bill? Okay, so there are no amendments on the bill. May I have a motion, please?
Move the bill.
Move the bill.
It's been moved and second. Any questions or concerns to the department regarding this bill? Seeing none, all those in favor say aye.
Aye.
Any opposition to this bill? Seeing none, the bill passes unanimous. Thank you. And we have the bill, the next bill, it's Senate Bill 734, which has an amendment and is the Maryland Healthcare Commission Primary Care Report and Work Group. Erin, can you tell us what it does, please? And to the department, thank you for being with us. We appreciate you. Go ahead.
There is a reprint of this bill on pages 19 through 26 of your packet. The bill requires the Maryland Healthcare Commission by December 1st, 2024, and each year thereafter to provide a report to the Governor and General Assembly that includes an analysis of primary care investment over the immediately preceding year, including data stratified by zip code and county in relation to total healthcare spending over the previous year, ways to improve the quality of and access to primary care services with special attention to increasing healthcare equity, reducing healthcare disparities, and avoiding increased costs, and any findings and recommendations. The Maryland Healthcare Commission must form a work group that includes specified stakeholders to develop the report, including by interpreting the results of the required analysis and making the recommendations. MHCC must also establish a plan for the analysis and report after receiving input and agreement from the work group participants and provide the plan to the Governor and General Assembly by December 1st, 2023. On handwritten page 24 of your packet, that is where the amendments that were presented by Senator Lamb during the House bill hearing appear. If you look on handwritten page 24 after line 15, in the definition of primary care, so primary care means healthcare provided in the following fields: outpatient settings, the primary care nurse practitioner services, and primary care midwifery outpatient settings are added to that definition. And then in addition, on handwritten page 25, the work group is required to include certain representatives, and this amendment would add representatives of the Maryland Nurses Association, the Maryland Affiliate American College of Nurse Midwives, and the Maryland Community Health System.
Thank you, Erin. And Senator Lamb, I see that you're here. Is it?
Yeah, I'm still here. And
Okay,
I think
great.
Dr. Half has joined us as well, and he was one of the witnesses on the panel.
All right, and can I ask you something? The Maryland Healthcare Commission, your amendments address the Maryland Healthcare Commission's concerns, correct?
Yes, they do. Yeah, and we did consult with them beforehand. They're comfortable with this.
Okay, great. Thank you. And Dr. Haft, can you tell us why we need this bill?
Yeah, thank you, Vice Chairman Pena-Melnick.
You're welcome.
This is an important bill because it addresses a critical need in primary care at the moment. Primary care is significantly threatened with losses in numbers of providers and also in terms of its essential role in terms of supporting the public health and prevention in our state and in the nation. This is one of bills that are seen similarly in at least 11 other states. We know that the primary care provides about 40% of all of the visits that occur to healthcare providers overall in the state, yet it's probably less than 5% of the investment in total healthcare, and it is declining over time. It's important for us to understand how much we're spending in terms of primary care and making sure that we're supporting primary care sufficiently in the state for the reasons of equity and ultimately reducing costs of care overall and improving the outcomes for health. We know from the reports from the National Academy of Science, Engineering, and Medicine that in the only place that we invest in terms of healthcare that reliably produces improvements and by increasing it, provides improvements in equity and also in better outcomes is in primary care. So it's just very important that we are able to look at Maryland, see what we are investing in primary care, make sure that it's sufficient, and if not sufficient, make recommendations to the General Assembly and the governor to make adjustments therein. This is a very broadly supported bill. The work group is inclusive of virtually all of the interested parties in this, and I believe that by favorable report on this, that will make the ability to make some significant advancements in health overall and equity overall and in primary care in the state.
Thank you. Thank you for your work to the state. We really appreciate it. Are there any questions for Dr. Haff or for Senator Lamb regarding this bill? Is there anyone else that wants to be heard from the advocates on this bill? Seeing no questions or no one else wants to be heard on this, there is an amendment on the bill. May I have a motion on the amendment?
Move the amendment.
Second.
It's been moved and second. Any questions or concerns regarding the amendment on this bill? Seeing none, all those in favor say yes.
Yes.
Any opposition? None. On the bill as amended, may
Move
I
the
have
bill
a
as
motion?
amended.
It's been moved by Delegate Lewis, second by Delegate Johnson. Any questions or concern on this bill as amended? Seeing none, all those in favor say aye.
Aye.
Any opposition? None. The bill passes unanimous. Thank you, Dr. Haff, for your service. Thank you, Senator Lamb, and for the advocates for being with us. Now we are on the last bill of the day. The last bill of the day is the following, which is House Bill 935. And I have it on here for discussion. And we have Delegate Bagnall. I'm going to actually call on Aaron to just briefly describe the bill. Then I will have Delegate Bagnall and anyone else that she would like to be heard on. Thank you, committee, for being so patient. We're on the last bill. Aaron.
There's a reprint of the bill that starts on page 27 of your packet. On page 28, it requires for each of fiscal years 2024 through 2027, the governor to include in the annual budget bill the amount of the immediately preceding fiscal year budget appropriation for wellness and recovery centers, recovery community centers, and peer recovery services increased by 20%. If you move on to handwritten page 30, it requires beginning on January 1st, 2023 for Medicaid to provide, subject to limitations of the state budget, measurement-based care provided in behavioral health care settings, including outpatient mental health centers. And measurement-based care is defined on handwritten page 29 of the bill. If you move on to handwritten page 32, this would strike the collaborative care pilot program that currently exists, but it retains current law requiring MDH to implement and provide reimbursement for services provided in accordance with the collaborative care model statewide in primary care settings that provide healthcare services to Medicaid recipients. Then there is language in the bill starting on handwritten page 33 that requires MDH to ensure that care coordinators delivering services under the section 1915I model or a mental health case management program receive training in the delivery of wraparound services under a high fidelity wraparound model. Going on to handwritten page 34, beginning in fiscal year 2023, Behavioral Health Administration must fund 100 slots in the mental health case management program for children or youth who are eligible for program services and at risk of out-of-home placement. The governor must include in the annual operating budget the following amounts to fund customized goods and services for youth receiving services under the 1915I model or mental health case management program. And that's $150,000 in fiscal 2024, $250,000 in fiscal 2025, and $350,000 in fiscal 2026 in each fiscal year thereafter. If you move on to handwritten page 36, there is uncodified language providing that on or before December 1st, 2022, MDH must obtain any federal authority necessary to implement a plan for the expansion of certified community behavioral health clinics in the state, including applying to CMS for an amendment to any of the state's section 1115 waivers or the state plan. It also requires MDH to review and consider options for expanding the services provided under section 151102 as provided in the bill, or adopting other existing programs or services to provide wraparound services under a high fidelity wraparound model to children and youth with primary substance disorders. Also, on or before December 1st, 2023, MDH must review current eligibility requirements for the model established under section 1915 of the Social Security Act and mental health case management generally, and submit the recommendations to the General Assembly. There's also a requirement that the Maryland Insurance Administration, in consultation with carriers, behavioral health care providers, advocates, and other stakeholders, conduct a study on operational issues related to commercial carrier reimbursement of behavioral health clinical peer specialists and crisis response services, and make recommendations for how to address those issues.
Okay, thank you, Erin. Delegate Bagno.
Thank you, Madam Chair. So you'll recall we had the hearing on this bill about a month ago, and it was a comprehensive modernization of behavioral health. But in working the bill, we had some concerns that were raised by the carriers, which is why we created that MIA work group. The MIA has already agreed to it. The carriers are on board. They're very excited about the possibility because the way that they require payment, it's kind of a square peg in a round hole. So there wasn't a way to create a reimbursement for the commercial carriers. So what's in the bill is the certified community behavioral health centers, because that is budget neutral, because they are federally designed and funded. The expansion requires only that the Department of Health apply for federal authority to implement the expansion plan. And then the expansion plan is actually in the hands of the department. The collaborative care model, which is focused on a program that we've already piloted. We already know that the data is really good in terms of the outcomes. That's that $775.30 per person per year that I quoted in the hearing. And the fiscal note reflects the analyst expanding it out to 60% utilization of the eligible participants. So that's where that fiscal note comes from. We also have a report that particular model actually has a $6 savings for every dollar spent, which obviously can't be reflected in the fiscal note, but we do have data reporting on that. The wraparound services for children and youth, again, that's that expansion of the 1950I waiver program. And that is a flat rate. We know what that is because we were looking at expanding it to another 100 waivers. That's that $471.34 per member per month. So we really tried to focus this bill on expanding what we know what works, and stretching those state dollars and also leveraging state dollars against federal dollars. The collaborative care model has a 60% federal match. The measurement-based care, which would only expand to Medicaid because we have to figure out, the funding for the commercial carriers, but that also comes with a 75% federal match. So if you look at the appendix 1 is the original fiscal impact, and appendix 2 reflects the analysis as the bill was amended. You'll notice that the certified community behavioral health centers are not even on appendix 2 because again, they're budget neutral. The measurement-based care, again, it came in a little higher than we were expecting. But when I talked with the analyst, she also mentioned that we could limit the number of waivers if we wanted to further limit the fiscal note. We could also work within the regulatory authority of the Department of Health. So the peer-to-peer services, again, that funding is representative of a proportional increase for the wellness and the recovery and the peer recovery, the recovery care centers. But because we have additional fiscal authority starting in 2023, that doesn't have to be in the bill. We left it in the bill to sort of identify the will of the General Assembly. And I didn't amend the bill any further because I knew that we were going to have discussion on the bill as amended.
Thank you, Delegate Bagnall. Who wants to be heard from the advocate community? I'm going to start first with Mr. Dan Martin. Then I'm going to open it when we're done to the committee, and then followed by Lori Doyle. Mr. Martin.
Thank you, Madam Chair. I really appreciate the time, and thank you, Delegate Bagnall, for introducing the bill. Just real quickly, I don't want to go through the whole hearing again, but this was really priority legislation for the Maryland Behavioral Health Coalition this year. We spent the last year kind of really coming together, 100+ groups coming together and saying, what can we do to address just this, huge increasing demand for mental health and substance use services coming out of the pandemic. And everyone put their heads together, and this is kind of the result we came up with. The idea being, we have a good system, but if we could just do a few enhancements, we could really have a great system. And so that's why the bill is called the Behavioral Health Modernization Act. It's really designed to kind of modernize Maryland's behavioral health system, bring it into the 21st century. And so it came in, as introduced with a big fiscal note because it tried to address a whole bunch of different things. But like Aaron described, like Delegate Bagnall described, there are amendments to really kind of pare it down and make it as lean as possible, to kind of and as targeted as possible. And what those amendments do, just in a nutshell, we've removed some provisions that aren't really ready for prime time. Medicaid reimbursement for crisis services, Medicaid reimbursement for certified peer recovery services. Given insurance carrier concerns that Delegate Bagnall described, and concerns about placing mandates on carriers, we've removed provisions that would require a carrier cover these different services, reimburse for these services, and like you heard, MIA has voiced their support for doing a work group during the interim, to look more at those services. And so what remains are really modestly priced and no cost provisions that will expand access to proven and validated and data-driven services that we know work. These things will expand. The bill as amended would expand, community behavioral health clinics, which are currently operating by kind of a demonstration type model. It will expand the collaborative care model, which is currently operating in a pilot program that's showing clinically significant improvement for 65% of the participants. And like Delegate Bagnall said, return $6 for every dollar invested. It would increase access to home and community-based wraparound services for children and youth, which are currently operating in a very limited capacity. And that's why we do these types of things in this state. We start in a very limited way so that we can evaluate these things and see if it makes sense to expand them. And so again, we have a pilot program for collaborative care. We have demonstration models, and we have limited in eligibility, and they've been operating, and we've evaluated them, and we know that they work. We know that they improve health outcomes. We know that they keep people out of crisis and keep people out of emergency departments and save money as a result. And so this is really the next step. We do these first steps, we create these pilot programs, we create these demonstrations, see if they work. We know they work, and we know they save money, and we know they improve services for people, keep people out of the emergency departments. And so, we've done a lot this session around crisis services, and it's great. We've been advocating for a long time to expand access to expand Maryland's system to make sure we have a comprehensive crisis response system. But if we only invest in crisis services and don't invest in the services in the community that keep people out of crisis and out of hospital emergency departments, we're always going to be playing catch up. And so that's why this bill is really, really important, to really kind of just increase the availability of those services that keep people out of crisis and out of the hospitals. And so, and thank you for the time.
Thank you. Laurie Doyle.
Thanks, Madam Chair. I just wanted to take a moment and speak to the CCBHCs, the Certified Community Behavioral Health Clinics. In addition to them having no fiscal note, what we've seen in other states is really significant changes in the right direction. So, Madam Chair, I know you of all people have dealt with people stuck in the EDs. We're seeing now that according to the Hospital Association, while ED utilization for other kinds of illnesses is going down, it is rising for behavioral health by 12% in the last 4 years. We're also seeing in ED boarding, people who don't need to be there anymore but don't have a placement. Those boarders, anywhere from 200 to 350 people at any given time, are boarding in our EDs, and 25% of those are psych patients, and they take up 68% of the boarding time. So that indicates that there's a problem here, and that's what CCBHCs are meant to address. And what we've seen in other states is significant reductions in preventable utilization of EDs and inpatient care. I will also mention that we have 5 grantees here in the state of Maryland, in PG County, Anne Arundel, and Montgomery County, and Baltimore City, that have received federal money to start their CCBHCs. It would be a shame to lose that momentum. And I will also mention that in the Biden administration budget, there's $300 million being put in for CCBHC implementation because it works. So there is no fiscal note on that portion of the bill. It is basically what we heard from you guys heard last bill about primary care and the need for primary care. This is behavioral health primary care. So we hope that you'll see fit to support the whole bill and particularly the CCBHCs. Thank you.
Delegate Lewis.
Thank you, Madam Chair. Thanks to the bill sponsor and panelists again. And it's amazing the amount of work that's been done to reshape this bill. I want to thank you for that. I guess that's really my questions have been answered. So I'll put my hand down. Thank you, Madam Chair.
Okay. Delegate Bagnall.
Thank you, Madam Chair. And I should have said this before, but the bill was really crafted in such a way and really focused to expand on this integrative care model, which really we have been moving towards, and we talk about a lot in this committee about equity in care and making sure that we're not treating behavioral health care as something separate to somatic care. And in fact, that the collaborative care model kind of partners those two in those primary care settings. So we really have tried to make this as lean and meaningful as possible. And the one thing I did forget to mention is in terms of the peer-to-peer clinical services, because currently there was a lot of federal money that came in support of substance use disorder. We didn't put this in the bill, but we were going to request a letter from the committee to ask the department to expand their interpretation of the ARPA funding to address behavioral health rather than just substance use disorder, because there's nothing in the federal funding that requires that it be tailored specifically to SED, and being that they are often comorbidities and often are also the same providers that are addressing those services, as we know from last year's adolescent mental health bill. We thought that would be appropriate, and again would be budget neutral.
So do you know, Delegate, right now with what you've done, what is the fiscal note?
The fiscal note from general funds is $7,120,000 for 2023, $13,041,000 2024. But again, if we strip out the allocations, the 20% increase, it would sorry, the 2023, the difference between 2023 and 2024 is simply that 2023 it's not the full year. But we could if we removed that increase, it would reduce it in 2024, 2025, 2026, 2027.
Okay.
Because that's the general funds, because then there's a federal match.
Mm-hmm. All right, thank you. And CCOT.
Thank you, Madam Chair. I realize I spoke on the other bill and did not introduce myself. Ann Seacott, representing the National Council on Alcoholism and Drug Dependence, the Maryland chapter. I just want to emphasize one of the last things that Delegate Bagnall said, that we are committed to ensuring, in the spirit of integrated care. Integrated means both in terms of behavioral health with somatic care, which I think speaks to things that have just been mentioned about the bill, as well as ensuring the integration between substance use disorders and mental health. And to that effect, we do hope that there can be a letter supporting our efforts with the department, that when we talk about really anything that we do, but including in this specific instance, that funding for certified peer recovery specialists, that is not limited to folks who are in substance use disorder programs, but also mental health programs.
Okay. I know Delegate Bagnall, your hand is up, but I want to allow the committee members to ask questions too, okay? So 1 second. Are there any questions for the delegate or the advocates on this bill from the committee members? Delegate Riley.
Thank you, Madam Chair. Yes, in one of the department letters, we're showing there's talking about two programs that we're already currently expanding on. Are those two programs going to be included in this bill, or we're just going to eliminate those and go forward? Are you familiar with those? The mobile crisis services and the certified peer recovery specialist?
So who's the best person to address the delegate's question?
It's in the governor's budget. Okay.
Yeah, Mr. Martin wants to address your question, delegate.
Thank you.
My pleasure. Delegate Martin, Mr. Martin.
And thank you, Delegate Pena. Thank you, Delegate Riley, for the question. Both of those provisions, the Medicaid reimbursement for certified peer recovery services and Medicaid reimbursement for crisis response services, have been removed from the bill in the amendment. So again, there's things that they're kind of already happening already a little bit in one area and aren't quite ready for prime time in the other area. That's why those things were removed from the bill. So
okay, thank you for that clarification. Thanks.
Thank you for the question, Delegate. Any other questions for Delegate Bagnall or the advocates from the committee members? Okay, Delegate Bagnall, going back to you.
Thank you, Madam Chair. I just wanted to mention again that I'm going by the fiscal note from the analyst, but again, I think sort of to the same point that Delegate Smith made, this was her estimation based on 60% utilization of eligible recipients, Medicaid recipients. And it is unlikely that we would be able to expand to the full 60% at the outgoing, because we still have to expand these services statewide. So I think that this fiscal note may still be somewhat inflated based on the actual utilization in the upcoming years.
Mr. Martin? Your
Yeah,
hand is up.
Thank you, Chairman Pena. Just one more quick, thought. Ms. Doyle said, that CCBHCs are really the primary care for behavioral health care, and that's right. But, I just want to point out that the collaborative care model really is primary care it's behavioral health care in primary care, it's primary care. And, as you just heard Dr. Haft saying, primary care efforts are being kind of underfunded, across the state, behavioral health being underfunded even more, and so, again, we do a lot to kind of provide resources for folks, on the high end and people that are entering the system, on the back end and at the most expensive level of care, but most people with a mild to moderate mental health substance use disorder, they don't go to a specialist at first. They don't go to the emergency department. First, they go to their primary care doctor, and unfortunately, care delivered in those settings is often really suboptimal, with only 1 out of 5 people that go to get care in those settings receiving, optimum care. But that's what this collaborative care model does. It really improves the delivery of behavioral health care in those settings, and makes it so that people don't need to go to
Can you
an
open
emergency
this one real quick? See if there's a revised.
Delegate Riley?
I'm sorry.
It's okay, it happens.
So again, so we know that model keeps people out of emergency departments, keeps people out of crisis, and I just wanted to kind of reiterate that point. Thank you.
You're welcome, Mr. Martin. Delegate Riley.
I apologize for that. I was just asking to see if we had an advised. Are we going to get a revised fiscal note on this bill? Because there's been a lot of changes. Are we going to be able to see that? Do we know?
There's a revised letter, and that's what
what she went through.
reading from.
Okay.
That's the best you can do unless the bill passes, they can't do an actual.
Gotcha. Okay, I'll have to just lay them side by side. Okay, thank you very much. Appreciate it.
My pleasure. Any other questions or concerns? All right, so Delegate Bagnall, I would ask you to meet again with the advocates and try to see what we can do now. Okay, because it's still pretty high, right? And then we're meeting on Wednesday because we have a couple more bills that we're meeting. And if you're able to work on it, and we can talk offline on some pieces now. And I think that you need to, in the interim, work on this bill a bit more with the advocates. Some things were not ready, as Mr. Martin said, for prime time, and just try to look at the bill and see what can be worked in the interim, because it still needs a little bit of work. But there's some things that perhaps we can do now. I know this is a very important issue for the committee, but we want to make sure to do it right. So we can talk offline about it, but we're meeting on Wednesday again. I wanted to give you an opportunity to present it today because you've done so much work. And I know that you have, and the advocates as well. So out of respect, I wanted the committee to see if they can give you some guidance or just had some questions. So thank you so much for all your efforts and all the advocates for your work. We appreciate it, all right? That is actually the last bill of, right, Erin? Of the day. So we did a lot. I just want to thank everyone for your time and your efforts. I hope you have a blessed afternoon. We probably will meet again on Wednesday for a couple more bills. Thank you so much for your work this session. We've done great work in public health, and that is because of your work and your efforts. So it matters. Thank you so much. Thank you, Erin. Thank you, Edith.